Good afternoon, everybody, and thank you for allowing me to be part of your day. Today, we're going to introduce some new concepts to the revenue cycle. It's always been focused on charges, and now we're going to start to see what CEOs and what other countries are claiming are the issue. So, first of all, we always have a disclaimer. It talks about the CPT codes are trademarked by the AMA. Revenue codes, if they're presented, are by the American Hospital Association. The information provided only intended to be a general overview and not for internal management purposes. So today's agenda is we'll go through the overview, the importance of internal controls. And we all know that hospitals have lived and continue to live in silos. So as an auditor, I look for internal controls. What is the control between point A and point B? And are we able to do that? And is it creating a problem? We're going to look at where data and tools can be used to enhance your outcome and break down those silos. Involve necessary personnel to break down the silos, and then the summary. Objectives for your CEUs, that you're able to identify two potential causes of lost charges, state the importance of internal controls, be able to state how to create an internal control, understand, for example, the inpatient only list is back with a vengeance, and how to create operational controls, and how data can assist you in identifying it. So in marketing, they call it the call to arms, but it's like, why now? What's changed? Well, what changed is the pandemic. It threw everything in healthcare internationally into chaos. And so now what we're seeing is that the per capita spending prior to the pandemic in the United States was about twice the average of other countries. So we spend more per capita, but we do not get the benefit that other countries get. So we see that diseases of the circulatory system, cancers, respiratory, external causes, mental health, all of these are contributed, and these are major causes for mortality. So we don't necessarily get that. When we look at the American healthcare executives, we look at what in 2023 are going to be the three top concerns, and they are personnel shortages due to burnout and people not signing up to go to school for to replace the retiring people, financial challenges because the cost to perform services is greatly increased, and quality and safety challenges to make sure that the preventable issues don't happen. These are also in the top 10 of the CEOs is a focus on population health management. When we look at personnel, their biggest personnel issue is nursing shortages, and they're paying top dollar right now to get per diems and traveling nurses and what have you. So this is not sustainable. The use of these has increased the cost to provide services significantly. The personnel are not always matched to the required task. So RNs are being used when a patient care assistant would suffice. So the mix that we had pre-pandemic may not be continuing today. And so they're just making one person fits all. It creates patient safety issues, quality and provision of concern issues. So as we look at that, comes along the focus on financials, was the category 2 of those CEUs. And that is their increased medication and supply costs. We have seen supply chain issues throughout the pandemic with masks, with surgical attire, with medications, and now we're seeing it with food groups and things like that. So supply chain is an issue. Increased payroll for contract labor. Capped and shrinking reimbursements. So remember, before we had the pandemic, there was a move to value-based, and that's still going on, but capping reimbursement. And the culture of fee-for-service requiring change to value care when capitated service is changing the focus. So we've got all these disruptors to the fee-for-service system, which America has lived on for many, many decades. And so fee-for-service has been the focus of these concerns, and now we're seeing the fruit of that fee-for-service. we looked at what the massive financial pressures are, and there's a higher mix of labor contracted versus employed. So we're up from 4.7% to 38% are now contracted, increase in contract hourly billing rates up to 213% pre-pandemic. So personnel and the cost to get them is significant. Fewer high margin elective procedures, and many elective procedures are still just now starting up again post-pandemic. Inflation increased supply costs up to 36.9% and increased medication up to 20%. And then the COVID vaccine and the COVID relief is mostly gone, yet COVID cases and now respiratory syncytial virus and the flu, they call it the tridemic, is occurring this year. So what is the true root cause? About half of everything we're doing in healthcare is unnecessary or preventable. Is it wasteful? And then what if half the hospital admissions were prevented because care providers moved upstream? Would we have a labor shortage? So these are two concepts we're going to be dealing with today. When we look at the waste and preventable management, we see 250,000 deaths per year are due to medical errors. This involves then litigation. It involves increased costs. It involves pain to the patient and their families. These are preventable errors, 250,000, and these come with a significant cost. Then the experts are estimating that about $1 trillion of financial waste in healthcare, and that was done by Dr. Brent James. And so we see that there has been waste, and the waste is endemic to a fee-for-service system. When I look now at a grid that was provided by Tom Burton, we're going to say the waste categories are on the left. Who should get the care and when? Case utilization. What care should be included? Is there variation within the case? Is each care component delivered efficiently? So now we're changing with shrinking reimbursement. We're changing into efficiency-driven facilities. So the first symbol we see is needs care, is the green men or women, and the receive care. So we see that we have some gray icons that received care but didn't need it. In the ideal state, only those that needed care would get it, and early intervention to prevent disease or injury. So we are a system on fee-for-service that spends 80% of our dollars in the last 20 days of life, usually, according to the Medicare back a couple years. So we're spending a lot of money, but we don't do early intervention. We are not on a well model. This country is culturally on a sick model. We get attended to when we produce symptoms instead of really focusing on the wellness. Now, if you are insurance and you have insurance today, you're going to start to see things like silver sneakers and discounts or complete payment for fitness programs and weight loss programs and mental health programs. What should be included in the care? Now we know the case rate utilization, but now we need the within case variation. So it's the same case, but it's varied. Why? We look at procedures, diagnostic tests, labs, drugs, behavior, and patient education. The current state is to throw everything at it. Oops, sorry. But then when we look at the ideal state, you're going to see less laboratories. And we start to see that from things like clinical laboratory ordering committees, less testing. So we're providing only the right care is included, avoiding duplicate testing, eliminate complications. So what do I see all the time when I do my audits? Patient comes in, they had chest pain. They get their 3 levels of heart studies in the labs, but then they get a BMP every single day for the day they're there. Why? They didn't have a BMP out at home. They're not being treated for it. This is a symptom of the litigation that's gone on in the past. So we want to avoid duplicate testing, eliminate complications with a less effective interventions. If each component was delivered efficiently, And time and resources. Right now, the time and the resources is significant. But if I was to look at this and lower the cost of drugs and supplies, technical and administrative process streamlined to reduce the cost. So when we start looking at supplies, CMS has said for years to provider practice patterns should be looked at, and that's why part of their stuff is regarding bundling. So you see here, we want to do the case rate utilization, kind of limit the within case utilization variation, and then promote efficiency. So what are the three models in healthcare? One, fee for service. That's what we've been solidly on, and I don't see it ever completely going away. But insurance pays care delivery system for each and every component of care. What we're starting to see more and more is facilities with payers increasing case rates, increasing day stays, increasing bundling, and things like that. So, for example, the surgical back procedure has 3 tests, an MRI, 4 medications, and 5-day stay. You're going to get every payment done. A bundle per case, insurance pays a pre-negotiated set amount for a specific type of procedure. And what we see is like $50,000 for a spine, regardless of how many lab medications or MRIs. So that's a bundled case. That is halfway between fee for service and capitation. Our ideal state started in the 1980s and then fell back a wayside again culturally, but capitation. Insurance will pay a pre-negotiated monthly rate for care of the population of the patient. Now, this means that the payer has to have risk. Otherwise, they're just going to be getting the benefit. So insurance agrees to pay $225 per member per month to a population of patients with back pain issues, whether they get the surgery or not. In full capitation, insurance pays $525 per month to care for all the issues within a population. So from step 2, bundled per case, that starts to see the advent of population health involvement, to full capitation, that is a population health requirement. So we're moving away from the initial issues of fee for service and into pop health. The other thing is going to be looked at is your access to care. So when we start looking at these alignments, there's a case rate is attributed to about 45% of the waste, within case 40%, and efficiency is 15%. So when we look at this, the fee for service model, we want to reduce the case rate utilization and the within case and increase the efficiency. On the per case model, we want to only provide services to those requiring it. And then we decrease the case variation efficiency. And then when the provider's at risk, that savings from waste elimination accrue to the delivery organization. So as you can see in the methodology to remove waste, we're looking at the green section on the far right, which is capitation, something that culturally Americans do not have quite an appetite for. So if I look at total revenues and total operating expenses, they create my net operating income. So when I look at what we do now, we increase procedures, we increase high cost procedures, we use more technology. We are still focusing on the 5 to 9% of the contribution margin by increasing the revenue growth through increased or enhanced procedures and charge capture. And that's great. 5 to 9% on a negative balance sheet is fantastic. However, if I get rid of the waste, I can increase 50 to 100% contribution for each case avoided. So on the top, I'm trying to get cases added. But if I only treat those patients who actually needed it in the right setting and the right testing, I can avoid some of these costs. So as you can see, the larger green arrow now becomes quite evident that the net operating margin and return on investment is moving ahead by the quality factors and eliminating waste. So when we look at this value creation framework by Health Catalyst, you see the best practice, see analytics, and then the adoption of those two elements lead to improvement. Improvement does not occur without a best practice model, data analytics, and adopting the framework. So if you've got silos, you can't adopt, so you're going to fail at the improvement. What we do know we should be doing is quantify the ideal process gains. What is it that the process is giving us? Identify the root causes, redesign and evaluate process based on evidence-based guidelines, expert consensus, and standardize the work. How do we measure that? We capture correct data about the process, integrate all relevant data, grant access to data broadly across the spectrum of providers, generate insight from data, and promote more informed decisions. At many times, we don't show the providers, that they are up against one of their colleagues and a colleague is a better performer. So we really want to start making data accessible to all parties. What I see in facilities is, I have an HIM report. I have a physician advisory report. I have revenue cycle reports. And I've got all these reports that don't tie, don't provide the ideal process, and certainly don't eliminate the root cause. So how do we transform ourselves? First of all, education has been a mainstay of facility healthcare revenue cycle as long as I've been around, and I'm a little bit aged. We have skills, knowledge, and attitudes. In addition, we have to accelerate adoption with strategy, competency, culture, and operating model. All of this is very difficult when the nurse has a 6-to-1 patient ratio and they can't even contribute. So we have to start looking at these, what is going to take to be able to transform. So what is the value we're shooting for? 1, health impact, lives saved, lives improved. That is the mantra of Health Catalyst. Using actionable data to improve life and save lives. Financial impact comes second with revenue enhancement, productivity gains, cost avoidance, hard cost reduction, and shared saving. And then experience impact, patients and families, clinician, administrative support. So we've kind of attacked all of these things at some point in time through our revenue cycles. We have HCAT scores. We've got all these different things to look at the quality and what have you, but we don't necessarily see a broad picture. So I'm going to go right ahead into the financial implications. And these are ways to improve outcomes while controlling waste. And first of all, we're going to talk about what internal control is. I use the University of Florida, and all credit goes to them, for both accounting for healthcare. There are 2 basic categories of internal controls, and these transition themselves very well over to healthcare. 1 is preventative internal controls, and the second one is detective internal controls. Internal control system must have both types. It's not an either or, and they serve a different purpose. So the revenue cycle is no exception. In fact, it's a great look at this. Both types are required to ensure compliant charge capture. UF also states that you perform routine process when you're thinking of implementing procedures and processes. It's important to ask the following questions. What could go wrong with this picture? What steps have been taken to ensure something does not go wrong? And how do you verify that nothing went wrong? Does this sound like a surgical experience to you? It does. It's a timeout and looking what could go wrong and taking action steps to prevent those things that could go wrong, and then to verify it if it does go wrong very quickly. So when we look at preventative and detective, they're completely time-based difference. The first one aims at decreasing the chance of errors and fraud before they concern and revolve around the separation of duties, meaning person A and person B are not in conflict. They're working in tandem, and they help each other in preventing a chance of error. So it's not one person. You separate the duties. You see this in accounting all the time with bank reconciliation. The person making the deposit deposit is not the same person that counts the deposit. So you've got that separation of duties. The second one is detective. And this is kind of where healthcare lives. They're designed to find errors or problems after it's occurred. So we see wrong status assignment after it's occurred. We see medication errors after they occur. So these are detective controls are essential because they provide evidence that preventative controls are operating as intended. Both methods are consistent and dependable data and analytics. When I look at preventative, the criteria is to decrease the chance of error before they occur and revolve around the concept of separation of duties. An example are timeout procedures in the OR, medication reconciliations that's required, inpatient-only list orders, prior authorizations, medical necessity, and evidence-based medicine. They're all internal controls that prevent the error from occurring. Detective it's data-driven in nature. Detective is different. You're going to take a conglomerate or a universe of data and start looking for patterns and trends and what can we do to improve. Find those aberrancies after the fact. This is one example I always see is when hospitals use data to look at readmission patterns. You know, what's the likelihood this type of patient with this diagnosis, with this DRG is going to have a readmission? And then if they are, take preventative steps to prevent it, meaning home care, frequent telemedicine, whatever it's going to take. So what I see as detective are claim checks. It finds the charge errors after the fact, charge capture reviews, CCI edits, duplicate charge capture, procedures not consistent with the diagnosis or coding, or sex-based procedures, the wrong sex, and denials. We do a lot with denials, but I don't see a lot of times where the denials actually flow back to the early part of the patient experience to make sure that we are preventing things. We just keep chasing and appealing denials. Now, a lot of that has to do with the payers changing the game rules constantly, and we can't do anything about that. But we can start to look at those patterns of denial and then take it up with their payer, your contracting agent, or the insurance committee. So what has caused this massive labor? And we talked about this in a fewer slides, so I'm not going to go through the percentage, but there are fewer high margin elective procedures are a big one. And the inflation and COVID is a big issue. So what is the true cause? We talked about those previously on a slide. I put it in here to make sure that we hit the theme again, that we're dealing with waste. The cost of medical errors, avoidable costs. There are two main types of errors. Errors of omission that occur as a result of action not taken. So not strapping a patient into a wheelchair, stabilizing a gurney. Errors of commission is the second type that result in the wrong action taken. Exclude administering medication to a patient that has a known allergy, or not labeling a laboratory specimen that's subscribed to the wrong patient. When I talk about medication administration, when patients have multiple accounts that are not linked to one MRN, you can see where one may have the fact that there's a penicillin allergy, but the second one that we're working off of doesn't. So it's very important when the patient access creates an account that it's linked correctly. And we have a lot of HIM work that goes into doing this every day. So this on slide 29 is a picture of all the control points. And as you can see, the left-hand side in yellow is before we start taking the patient experience face-to-face, you know, the clinic office visit, readmissions, emergency room. It goes through admitting, and that is the first place where we see a huge number of errors. Then we have the inpatient side, the outpatient side, the outpatient surgery, and the inpatient. Those are different tracks, shall we say, all before discharge. Now, the key here is that at the point of discharge, this big box on the right, everything has to have been accounted for. It has to be reconciled, and there should be no errors. So that's a big problem that everybody really labors with, because these EMRs are complicated and we don't always have insight into all the errors before they go out. So each point above must have a preventative and a detective model around it. Focus should not change, no matter if it's fee for service, capitated, managing costs, providing safe care. The focus never changes. Each point gets a preventative and a detective, with the outcome being optimal health, saving lives, and decreasing costs and increasing efficiency. Imaging next steps move forward on an outpatient care focus. So here is an audit cycle. This is what you use in finance. This is what you use in healthcare. This is what you use in manufacturing. It's the same cycle. This one happens to be from National Health Service in the Scotland area. You set the standard. What is the standard going to be? What am I going to say it's going to be? Maybe it's going to be no registration errors for Social Security number. Then the measuring the current practice. What is in the system? What does the technology do? Compare the results. Am I still having errors? Then I change the practice to make sure I've captured everything, and I re-audit. So this is how every point is preventative and detective. Detective is where we measure the current practice. Preventative is in when we change the practice based on the results. Charge cycle, overcoming the silo management, we have a different predictive and defense capture cycle. One, definitions. What is the objective of this audit? What are the standards? What policies and procedures? And this is important to use the correct standards for policies and procedures, because if you're setting forth a preventative and defensive internal control, it has to be based on the correct thing. So in the prior example of the Social Security number, a set of policies and procedures that discuss the time frame for admitting an inpatient to the inpatient bed does not cover the Social Security requirement. Data elements. What are the data we're going to use? And it's going to stay the same. Specific review of data elements against the standards. Published findings. These should be broad-based and should be out. So what am I getting at here? Corrective action. We're talking about using large amounts of data to manage ourselves and create efficiency. So a data-driven efficiency through the to overcome silo management through these control cycles. So it's at the expectation of every charge capture, follow the steps. One, change must be noted as a variance from the prescribed techniques. What preventative or detective point failed? The charge cycle can be implemented for any charge capture using the 5 steps, and the objective is to apply preventative and detective approach to each control and to be sustainable. And when I say sustainable, we have to be careful, because we can put all this great stuff in and have a great cycle, and then guess what happens? We have a new fire next day, and we're going to focus on that fire, and we're going to leave this one smoldering. So what do I see in facility is we never fully overcome the smoke. We just constantly are fighting fires, and you have to kind of stop, take a breath, and say, with data, how can I move this forward to prevent the fires and accurately address them once they're there? Technology and detection that Catalyst offers, or VitalWare, is CDM and knowledge, correct coding, vital integrity, accurate charge capture, and root cause remediation. So am I seeing that every single ER visit is a level 3, and that we're not seeing the variance in there? You know, did I have level 5 ERs that don't come with any laboratories ever? And, you know, what's missing there? Power costing. This is very big right now. This is activity-based costing. What's going to take your activities, your procedures, and it's going to provide costing that is attributable to the case level. So you can start to see Is there some activity or lever that I can change to increase the cost efficiency? Power labor is a huge thing in demand right now because of our labor issues and costs and acuity. And so we want to see labor. Where is the best bang for our buck? What is the mix of the labor that we need to provide to lower our labor costs while providing satisfaction? And one of the issues in nursing right now is it's finally caught up to all the years internationally where nurses have been kind of second nature, and they don't get the pay, the recognition, the staffing. Whenever there's a cut, they cut, administrative, or they cut nurses. Well, the end result is now we start to see strikes. Strikes are, I don't know if you've been reading about National Health Service in the UK, but all the nurses, 100,000 royal nurses are on strike. So this is where we're starting to see power labor provide those satisfaction goals by providing the correct staffing patterns. Clinical quality improvement is very important. Focus on the variations and look to the margin. What is avoidable? How do I get this clinically? Population health, as I said before, management of patients to achieve maximum wellness and move to capitation. That component alone is a huge factor in CEO discussion. So when we're looking at CEO discussion, we talked about preventative with the coding and the vital integrity. We talked about lowering our costs and labor, and we talked about increasing in efficiency through quality improvement. So that's kind of the financial transformation suite. So before I go on, I don't see any questions, so I'm going to move on into phase one. And this phase is really starting to get attention, but it is the stage that causes the majority of the denials. So when I look at phase one, it's the clinic, it's the office, it's readmissions, it's emergency. What happens in these areas that creates either enhanced cost, over-treatment, treatment in the wrong setting? What is the issue? So when we look at this, 61% of initial denials that are not fatal are due to demographic and technical errors, followed by eligibility at 16%, medical necessity at 12%. So 42% of denial write-offs are due to demographic and technical errors. Okay, 42%, 61% of initial are completely avoidable. And so we're starting to see the denials team really work with that front end. So is the authorization number I got from the physician's office for the surgery, is that the correct one? Eligibility, especially when it comes to cancer treatment, is that patient eligible? So if you're in a state like Arkansas, you can sign up for health insurance every month. So what the issue is that card on the first of the month, you were registered 2 days before at the end of the last month, is that on the first day, are you eligible? So we're seeing a lot of problems just in the whole process of eligibility. And then authorizations. If you talk to authorization nurses or PAs or paramedics, you're going to hear that they were online for 2 hours to get an auth, and then the payer wouldn't auth the full thing. So you're going to see a lot of struggles to get this 61%. So where are the control points? Physician's office, you're going to educate them. Clinics, emergency, planned admission. These are all control points that you can put in a defensive and a preventative step. So in the physician office, the preventative step is validating the authorization, validating the demographics. Clinics, is it the correct patient? Emergency, did they come in as a John Doe? We need to correct that. Then key objectives. They have to be clear and concise policies, accurate demographics to reduce denials, and consistent use of eligibility technology in a standard fashion. So let's talk about that right now. If you're in patient access, you're probably screaming at the top of your lungs right now. There's eligibility technology within most computer systems. However, different payers decide they don't want you to use the eligibility system within your computer system. They want you to use their portal. So, you've got certain people going off to do this. So this is where it becomes very concerning. And if you have enough staff, you need to organize them by payer, so that one person is doing all the Blue Cross authorization and eligibility. One person's doing the Cigna, United Healthcare. Because remember, within these major groupings of payers, there are plans, and those plans are very disparate. So the accurate demographics is the preventative, using the inpatient only list on surgery scheduling, making sure that that is not an inpatient. If it is, getting an order. Contract visibility. This is one thing that I see all the time. Contracts are not shared with the appropriate people, or the contract management cards, the cheat cards that we use in patient access, they're not up to date. So maybe it says this patient doesn't require authorization for this procedure on the card, but that was 2 years ago, and now they do. So making sure the visibility is correct. Detective, avoidable denial data. Look at the initial denials for failed demographics and just work with that. When I look at what the controls like, preventative, create the policy and procedure, and that's setting the standard to ensure that Medicare patient who's planning to have a procedure such as an inpatient only is following all the CMS guidelines. The same thing goes for patients who are going to have a joint replacement. There are certain documentation requirements that have to be met. So do you have the physician office records to be able to include it in for your joint replacement? So if I just take inpatient only, get the CMS list. Work with IT to develop a mechanism stopping the admit process if the patient has a procedure scheduled that's inpatient, but no order. Alert care management. The team is on an inpatient order. Ensure the operative report is reviewed and provisional complete within 24 hours. So this is a big thing with this inpatient only procedure for Medicare. If I come in and I'm an outpatient, and my procedure is deemed to be an outpatient, but something goes differently than I had planned, and I now have done an inpatient procedure, it's important that that coding happen by the next day so that you can get the order for an inpatient only procedure. So this is very important. Review all the criteria prior to discharge. Don't discharge without the appropriate stuff. Consider payer-specific registration. We talked about that in preventative, assign people to payers. Technology that prevents filing demographics unless complete. So a 6-digit social security number, most systems won't allow that. And then one of the things is my own personal peeve is most systems have this thing called recall, or a method of recalling the last known data. So when I hear the registration staff or patient access staff, they'll say, "Do you still live at 1234 Hill Street?" And the patient, they're kind of zoned out. They're like, "Yep, yep, yep, yep." And then all of a sudden you have the wrong information. The better question is they're teaching patient access professionals to use open-ended questions. Can you tell me your address? And then you can look at that. Who is your husband or wife's employer? Who is your partner's employer? Start looking for this and then correct it in the system. What I did a huge audit of thousands and thousands of records where demo recall was used in a system, and we had the wrong eligibility, and the only reason we were auditing it is because they failed. And we found that the registration graph at night was predominantly using demo recall. Defensive, as I've said from the beginning of this, is data. Denial management, were the procedures that failed the requirements. Surgery is anticipated to be an outpatient, becomes an inpatient. Demonstrating provider is involved. Incomplete HIM coding. Look at your data. What is missing? Use data to associate the registration staff to the errors and retrain them. Now, what I do see is they'll say, oh, this person is making all these errors, and it becomes a punitive measure when you really want it to be an educational. Nobody really comes to work thinking, hey, today I really want to do the wrong thing. It's usually due to confusion, misguidance, something like that. Use internal technology to associate incomplete fields associated with denials, and then stop it. Don't let the registration process go on any further without that. So now we've completed the majority of our preventable steps with the denials. We're going to look at the most significant internal controls and technology resources are consumed within phase 2. If I look at phase 2, I have the red, which is the inpatient track, the light blue, which is the outpatient track, the really bright green is outpatient surgery, and then we've got the lighter green, which is in or out surgery post-op. So this is where the majority of our data goes. We look at medications, we look at orders, we look at combinations of medications for allergies, we look at the progress notes, EMR, problem lists, all sorts of things go into the data. So when I look at that, phase where most avoidable costs and denials occur, focus on the preventative internal controls. So right patient, right time, right place, right service, right location. So that's the 5 R's. Am I providing this patient with the right service at the right time in the right place? What does that sound like? A status assignment. Should I have provided the service in an outpatient venue or a home health venue or another venue other than acute inpatient care? Am I providing the right service, or am I providing more than what's expected, and the right location? Objective is to have cost managed, quality provided care devoid of error. So this last statement is your goal for phase 2, is cost managed quality care provided devoid of errors. When I look at phase 2, the key control points are inpatient services, care management, patient access, utilization review, HIM, outpatient services, the clinics, the ER, surgical services, in and out, emergency, and infusion center and oncology. These all prevent a great opportunity for both preventative and detective internal controls. Quality outcomes and controls of clinical variation is very important on this phase 2. Let's not have one person take 12 hours to do the same surgery that every other physician takes 4 for. What is that issue? Start to really dig in and be open to whatever's wrong in your backyard. You have to be open to the data, what it's telling you. Start looking, think out of the box. Revenue and cost management. Instead of just looking at the revenue component, we really need to focus on cost, because our cost to provide per capita is double the average. So we need to start to look at, is that MRI really required today, or can we do something else? Labor management. This is a big issue because what I'm starting to see is we don't have the right people in the right jobs. Okay. So in the ER, we're hiring all these nurses, but could a paramedic provide the same level of quality care? Can we have a mix of nurse and paramedic and associate caregivers? What does that mix look like? So I see some places where they're all RNs. They're all BSN RNs. Or masters. It's like, is that the right place for them? Where I work in an ER, and I think the paramedics do an absolutely brilliant job. Preventative. We have this technology that we can use from VitalWare and from Health Catalyst. Clinical outcomes. What are they? Well, there's all sorts of clinical outcomes that are specified by the facility. The question is, do the average worker understand the clinical outcomes in the process, Or is this just at a high level where it's at the board and the CMO and the physician level and the chief nursing officer? What about the average everyday professional? Do they understand what these clinical outcomes are supposed to be? Are they participating in that? Power costing, clearly for cost management. We're going to see a lot of that with OR and OR management and in pharmacy management and device management. We're at power labor. We've talked about that. We have MCC, length of stay accelerator. So do I have a lot of patients that have a geometric mean length of stay that's been exceeded, usually by not a few days, but by more than the GMLOS, and that only has a single CC? Did I code this right? And what happens now, and especially in pop health, is we start to see our hierarchical coding, HCC, really start to take place. Are we capturing all the HCCs to really show the payers the risk we are taking on for these patients? And this becomes a key episode of population health within the capitated market. Detective, we look for lost charges, suboptimal clinical outcome. So increased length of stay, rework claims, denials. When I talk about lost charges, it's simple stuff. Are we still fighting on start and stop times with the IVs? Are we coding them correct? That's one of the few areas still reimbursed separately. Are the drug codings right? What about our wellness care? Are we charging that? Suboptimal clinical outcomes. What's happening there? Why is it suboptimal? Is it a social variant? So we're starting to see the social variants of care become very, very, very important in the efficiency, in the quality. Is there a population at risk from the social variants of care where that's suboptimal clinical outcome? And so, for example, you have a homeless person who has cancer, who comes to the ER for pain management, who has no follow-up care on the street. And so, there's a suboptimal clinical outcome. Or sending a patient who does not have any funds to buy medication with a prescription. How are they going to get the meds? So we start to see these social variants become very important in patient care outcomes. Preventative, non-technology, ensuring that each person reviews the prior internal control. So when the ER nurse sends a patient up to the floor, double check, is this your name? Is this your social? Is this your address? CDI becomes a focus to measure outcomes, not just reimbursement. And what I see is a lot of CDI teams out there, clinical documentation integrity team, they just measure for reimbursement. Oops, I missed a CC, or I need this. Ensuring all required documentation is present prior to surgical events. I cannot tell you how many joints I've looked at that have no records from the physician's office showing the required less than surgical treatment, the medical treatment, the physical therapy. Pop health, ensuring post-ED event has necessary care to prevent the recurring. Are they using the ED as their only source of health care? Non-technology, every step should be diagrammed. And this is where I see a lot of benefit. If you can diagram the process, you can show where the handoffs are. Okay. Focus on care management to ensure that inpatient auths and discharge plans start from the point of admission as an outpatient or inpatient. They start from the first intervention. What's this discharge going to look like? Is this a patient who's going to be an outpatient, but going to require home health? What does this look like? When we look at the example of complete and accurate charge capture, we created daily revenue cycle reconciliation policy and employ technology, software that compares CPT to CPT and CPT to ICD-10, CM, and PCF. Software should cover both compliance and revenue concern. Adaptable to specific cultures. So what do we know? No single department or institution does it exactly the same way as another location. So if I have an x-ray department at St. Elsewhere Hospital and I have an x-ray department at Downtown Hospital, the chances of them doing that same charge capture the same way is minimal. It's very coincidental. Medication charged without administration is a big one. How in the world did the medication get in the body? And this becomes really important when we start to accidentally charge patients for administration of white bag products or brown bag products. Technology requires human interpretation and root cause remediation. So, is technology the answer? No. Is it one of your greatest assets and tools to help human review? Yes. A human can't process all this as quickly as a computer does. So I look at, here's an example of a drug on a claim without an administration. If I look in the lower left, I see that the drug J0202 that's represented must have one of these administration routes. If it does not, this charge should be stopped until it's corrected. Therefore, this is preventative. One of the things that Sister Irene Krauss has been known for is no margin, no mission. So if I don't have a margin, I can't fulfill my mission to the community, to the patients, to the caregivers as a whole, that I can't continue to operate. And we start to see the no margin, no mission happening a lot with rural healthcare these days, where they're closing more rural healthcare because they don't have a margin. So how do we protect your margin? You can either increase it through volumes and reimbursement, which we showed before is going to increase that margin 5 to 9%, but it's very cumbersome. You can aggressively manage your costs through patient activity costs and evidence-based practices. One of the things I see a lot of evidence-based practices for managing costs now is in residency programs, where a senior resident has to sign off on certain procedures, or a fellow or an attending. So the residents aren't ordering up hundreds of $1,000 tests. They're not doing repeat. They're starting to look at the clinical ordering practices of the residents and training them to be more efficient. Lost charges continue, so you're going to continue with that. And then utilizing control points to examine the prior steps and use data to predict potential future failures and address their known failures. So basically, I'm going to use what's going on today. I'm going to look at it. Do I think that's right? If it's not right, what's the root cause of that? So for example, we see all the time in our line of work where we see a single chamber pacemaker has been charged and the procedure itself is a dual chamber. Why is a single chamber charged? Because the supply chain put the wrong code on it, the wrong HCPCS code. So there's simple things that you can start to use data to detect these aberrancies and correct them. Linking cost to patient activity is important. So you organize departments into accounts into meaningful groups. You're using ADP, you're using time cards, you're using the general ledger, the income statement, the patient care rates, the ICD-10 codes, the CPT codes. Then I'm going to identify the activities that drive costs for the services and products you provide. And then third, I'm going to link the cost to the activity. Is there an activity we do that isn't necessary on all patients, but is being done on all patients? So we can look at this. This is an example of power costing. And cost management has preventative and detective. Reviewing preference cards, okay? How many preference cards contain a whole lot of stuff on the card just because you think the physician might want it? Because of physician behavior, they get annoyed if it's not on the table. Or can I create a preference card that's the base kit for every surgery of that particular type, and then use the closets to add on additional things without opening them? Once you open them, then become a cost. Do I really need to open it just to have it immediately available? Or can that split second to open it be fine? utilization review committees to limit incidental testing. We see appropriate use criteria now being used, especially in radiology, where you need the AUC from an ER to get the CT or MRI and the MIPS standards around it. Evidence-based medicine guidelines. Patient in the best level of care criteria. We see a lot of fights with insurance payers on status. And a lot of times I see that it's just a fight about reimbursement. But the question is, if they're in a inpatient setting and they go home to nothing, was that status correct? Or should they have been in observation and created a discharge plan that had home health? So we start to see these old walls coming down. Detective, managing waste of opened items in the OR. Use data to identify potential readmissions. And I'm going to go back to the top one, managing waste. As of 10 years ago, the Cardinal Group said that about 35% of things that were on the table and open were never used. They were straight waste. And we're seeing that increase even more today. Data to look at downgrades. Should the patient have a different level of care? Use data. What patient activities are ripe for lowered costs? So are we bringing patients into a higher cost alternative? And we've seen quite a move from inpatient procedures elective to outpatient procedures, and even more so into outpatient surgery centers. You know, that where can we get that best cost? So much higher financial gain is happened by the operating margin from eliminating waste. So for example, I have do nothing and I have one preventable heart failure admission. The fee-for-service revenue is $25,000. Our cost to deliver $2,000 given to our net operating margin. So we didn't exceed the geometric length of stay. We beat we got a good DRG. It was all coded correctly, and we made $2,000 to the net revenue. However, if I'd have done the heart failure issue at preventative heart failure admission, in a preventative investment of daily weights and telemedicine visits and outpatient nursing, would have cost me $1,000 in cost. So the cost avoidance is I avoided $23,000 in cost above. So the inpatient cost of $23,000. So I would have added to the net margin $22,000. As you can see, the elimination of waste and cost management actually leads to the net operating margin. So people start to think, you know, we have these back in the PPACA days and the Affordable Care Act, they talked a lot about medical homes. They talked a lot about the VA system and how they do telemedicine. We're starting to see more and more with behavioral health. So we want to look at how to eliminate the waste. So if we go back to that grid, we see that we have taken care of all of the aspects. When the care should be gathered, what should be included, and is it done efficiently. We've moved more to the provider at risk. When the provider takes more risk, then they actually make more money. So phase 3 is your last step to fixing things. Control points are inpatient, outpatient, ASU. And the objective is a healthy population seeking optimal level of health without medical error and high quality outcomes. That is the objective of every patient in every setting every day. Healthy population, not sick population. Healthy population seeking optimal level of health without errors and high quality outcomes. Preventative methods are to engage and optimize post-discharge care. We have a company called Twistle that has software and engages a patient, and you see much better outcomes and less readmission. They have substance abuse pathways. Detective readmissions data, return to emergency visits data. We looked at one emergency room and it literally was doing nothing but managing where a methadone clinic or an outside substance abuse clinic 24 hours a day would have been the better opportunity, because the reimbursement was so low, the cost to provide was the ED, and it should have been done in another level of care. So when we move value to focus on the patient as an outcome, we start to see that, like something preventative and detective control points in patient compliance with their regimen, it becomes a technology-driven thing. And so this is where we see our chronic care management codes and things like that. But 93%, when the software was implemented, improved patient satisfaction. 30% reduced length of stay because we could move them to a different environment. Reduced readmissions by 38% and reduced the no-show rate by 30%. So a no-show rate of 30% means that 3 out of every 10 patients were showing up for their care. That meant reimbursement. But if you lost those 3 patients, you had them on the schedule, you plan for that reimbursement, you're losing your margin. So again, when we focus on the patient experience as the outcome, we do a lot better than just focusing on fee for service. Then the human component, and you're going to need the slide deck to expand this and look. But if you look, there are a lot of players: nursing, medical providers, care management, HIM, CDI, finance, compliance, IT, denials management, contract management, cost accounting, project management. All of these individuals affect the patient quality outcome in some fashion. It can be any or all of these that are involved. One of the things I see a lot is IT leading the charge based on some statistics, and they create a template that is not operable by providers or nursing. So it is, we use detective to start to look at why are these templates not being used correctly? Why are we not getting the patient quality outcome documented? And then you have to revise the template. So you see that all of this is cost and labor involved. Nursing shortage, we talked about post-COVID, is acute. They've been paying a premium, but this is not sustainable. The biggest facilities in the country are saying they can't do travelers. They just can't keep paying this. And the culture's needed to change and attract and retain high quality nurses. Less people are going into nursing because the pay isn't great and the hours are long. And what's come out of the COVID is it's really affected family life. So we see the burnout. We see the burnout in physicians and how many years after they're done with residency, they stay in medicine. Fear of retribution or criminal charges. This is the big one. There have been some cases recently where medication errors were made. And if you look at the case, the nursing staff or the physician was clearly overwhelmed with the patient load and the ability to help, and was acting very quickly, didn't follow all the steps. And so they were found criminally liable and sentenced to jail. So more and more, we're starting to see insurance companies for malpractice not cover criminal liability. So we're seeing an exodus of nurses saying, look, this is just too high risk for me for the pay. Inability to care for the patients. That's the number one reason. If you go home feeling guilty every day because you couldn't provide the quality care the patient deserved because of the staffing, that's an issue, and it's going to burn out. So one of the articles, and quite frankly, this article is a scare article, but it incites a lot of thinking. A charge nurse in an emergency room. This hospital kept downsizing and cost alignment and labor alignment, but not in an appropriate way, to the fact that the nurses in the ER couldn't keep up with the patient volume. So what did the charge nurse do? The charge nurse had to take care of the patient. So she called fire services. and had ambulances and paramedics sent to the hospital to manage the patient load through the shift. Now, obviously, the county commissioners got involved and the CEO was dealt with and what have you, but it shouldn't get to that point. I have worked in hospital emergency room where patients have called 911 to be transported to another hospital because they've been in the waiting room for 8 hours and they just don't feel good, and legitimately so, not like seeking. So we have problems, a high cost environment. We're not getting the mortality and morbidity we think we're going to get for that price. We see the system starting to decompensate post-COVID, both financially and from a labor. So what is this fully integrated team? If a silo develops where budgets, where gross charges can become border disputes, and where do I see this most often? Respiratory. Respiratory uses CPT codes to charge for their stuff, but they just keep going up and seeing the patient, and it's just a standard of care. So all of a sudden, if you cut that down and you say these are not chargeable, these are statistics, then their gross budget goes down, and then there's a border dispute. IT is too tailored to a provider. If you go into a facility, you ask, how many provider templates do you have? I have 15,000 physicians and I have 255,000 templates. That's a problem. You're not going to be able to control the documentation. Culture of the facility. Does it encourage interaction from the board level or reward when the department excels? Generally not. We usually punish those that are not meeting an expectation that may or may not be accurate. The big thing, when staff don't feel valued, they basically shut down. They do the minimum. And then fail to focus on quality patient care and outcomes provided in the most cost-efficient method. So if you know you're going to have an ER volume of 100 a shift and you're only staffing for 50, you're going to have patient burnout, you're going to have staff burnout, you're going to have negative complaints, you're going to lose volume because patients will go elsewhere. So what do? Every control point requires team member intervention, and they control it. Every control point mandates a team review all aspects of the prior step. Did you make it so complicated that they can't do it? Every control point serves as an opportunity to ensure reimbursement, manage costs, and contribute to the quality outcome. So when you look at consulting firms, they go out there, what do? They look at each of these control points and they said, is there an opportunity to decrease costs, manage the labor, or increase reimbursement? It serves to ensure patient service changes are not lost or charged erroneously. So phase 2, you're going to review everything in phase 1. Medical, you're going to confirm that all the performed allergies, medication, demographics, reason for presentation, eligibility. So you're going to quickly look at all of these items before phase 2. In phase 2, you're going to do the preventative, create and complete daily charge reconciliation. All of this has to be done before phase 3. And where do I see a lot of difficulty with this? In trauma services, where the field location, activation isn't documented, or it's critical care, but you don't have a policy on facility critical care. You're using the physician's policy, but CMS specifically states you can't do that. So we start to see these things in preventative, making it easier. We look at the OR flow sheets. Are all the supplies and devices charged? And remember, OR charges by exception. So everything on that preference card is going to be charged, except those that are noted as not being used. HCPCS code for devices. I can't tell you how many devices I see of a high dollar that are coded incorrectly. Charges only partially represented. So injection of chemotherapy without the chemotherapeutic agent, and it wasn't a white bag. Team members are responsible for creating policies and procedures to prevent these losses. Charge capture, an example where technology to assist. Due to the sheer volume in charge capture, hundreds and hundreds and thousands of transactions a day occur for charges. No human being could ever Look at 100% of the universe of charges from the day before. You're going to need technology. Every control point may have been reviewed by the team accurately, but then after the fact, somebody changed something and now it's wrong again. Assistive technology is required to get everything done in phase 2 before it goes to 3. Here's an example of assistive charge capture, where you've got a workflow status into the workflow, who's assigned to look at it, what the root cause is, the billing ID that compares CPT code to diagnosis, whatever. But here's an example. And usually there's about 1 million of these rules. So when you look at this, there's no way a human being can look through the thousands of charges and compare them to 1 million different rule sets, variables to catch these things. We look at then, if I go into one of those, as you saw before, might be like I have a missing procedure. And the reason I know that is I have these drugs on the claim, but I don't have any injection. I don't have any administration. So that's an example. Discharge is your last chance. Remember, once discharged, all things are final. And you see this quite a bit with like condition code 44, outpatient, inpatient to outpatient. It specifically states it has to be done prior to discharge. So what do you want to do? You want to start phase 1 and phase 2 before discharge, and you work with care management, utilization review to make sure at the time of discharge, all the orders are there. So what do? You may hire somebody who does a quick scan of the discharge to make sure all the documents are there. Do I have 7-day admission where 6 days of the orders were verbal and not co-signed? That's a cause for alarm, because with the time of discharge, you want all your documentation to be there to support the billing. So in summary, external forces, rising costs, subsequent improvement quality and mortality and morbidity. So we see cancer treatment in this country, the costs, while excessively high, are coming down. The labor is very specialized and managed well. And we see the mortality and morbidity of somebody with cancer decreasing. So they're not dying from it. We see if we have a decreased labor pool requires outsourcing, and we see it everywhere. It's not just nursing, it's radiographic technology, MRI. We see it everywhere. We see locum tenens for physicians. A need to move from fee-for-service to more capitated to provide that experience to the patient. But the American culture demands access to healthcare, but disparity in delivery creates ongoing concerns requiring a significant shift to population health metric. So if the patients don't have access to care, or they have to wait 6 months for an appointment, where do they go? So we see the increase in what we call retail medicine with CVS and Walgreens, with the minute clinics and things like that. We see urgent care popping up. We see walk-in clinics now starting at hospitals to gain some of that back. Facilities need to focus on preventative services and avoid the costs. So if I have a specialized CHF Center for Excellence, what am I doing to prevent these patients from being admitted? Control points are key. It breaks down silos and changes the culture to incorporate other teams' role by understanding what the other people are doing. Change thought practices from performing more volume to increasing the margin. Don't think about the volume, think about the margin. Review prior steps to ensure steps are completed. Use discharge criteria. Incorporate technology along all the human control points for synergistic outcome. So it's not a human being. It's not an auditor. It's not a nurse. It's not a utilization review. It's not patient access. It's all these human beings plus technology. Your objective is to control wastage, provide the highest cost-effective care, the highest quality, no medical errors, in the right place, right time, right setting. We want to control unnecessary death and suffering. unnecessary time and energies. These are mandatory, especially the unnecessary death and suffering. Health Catalyst, our mission, and it might be yours too, to be the catalyst for massive, measurable, data-informed healthcare improvement. Well, if you look at a lot of your tertiary care centers with medical schools and whatever, they're trying to be data-informed healthcare improvement clinically, but they only look at a sliver of the provision of the care. So you may have somebody working pop health or somebody working social determinants of care. What you need to be is an all-inclusive viewpoint. So at this point, I'm going to take a breath and see questions. Didn't the nurse get fired after 911? The nurse was, to my knowledge, terminated, but then the board of directors had to meet with the city council and the mayor, and there was some sort of remediation done. I don't know if the nurse still works for that facility. The articles have not been updated since the city council basically took the CEO and the chief nursing officer on, and they have to make rectification. But should they be fired? Probably not. HC webinar, oh, that's me. So I don't know the outcome, but if you're a nurse and your license depends on it, and you think people are going to die, I mean, you're in an ED, it's not like they're just showing up usually for non-emergent methods, or you're going to miss something. I've known other nurses to call 911. We see patients call 911 all the time. So is this appropriate? No. Preventative, all these things should have been in place prior to this happening. So calls from nursing were not heard, and that's an ongoing issue with facilities. The calls by physicians go out and are received at a higher intensity than the call from the nurses. So if the ED director called 911, then you'd have had a different outcome. So that's all the questions we have, and I think we ran out of time. So I'm going to close, and feel free to go ahead and contact us if you have any further questions. I'm going to turn it back over to Marie.
Great. Thanks, Bill. That was awesome. Lots of great comments about a great presentation. So thank you for doing that. We are over time, so I will make this really quick. Really quickly, I'm going to launch a poll asking if you would like to learn more about our VitalWare by Health Catalyst products and services, asking if you would like to schedule some time to meet with us and learn more. And other than that, like I said earlier, the email with the CEU information recording and slide deck will be sent out by end of day tomorrow. You can reach out to me personally or our HC webinars at healthcatalyst.com email if you don't receive that or if you have any further questions. And we do have 3 more webinars for the year next week. The CPT update series on December 13th, 14th, and 15th. You can register for those on our website. And I think that is all for today. Thank you so much, everyone, for joining us, and have a great rest of your day. Thank you.
Bye-bye.